morning to all of you. I have great pleasure in inviting my good old friend Dr.Unnikrishnan, who is currently the CEO of Trivandrum Diabetes Institute at Pune, to speak on this very important topic of in-hospital management of diabetes. As we know, diabetes is a problem which is seen in more than 1/3 of patients who are admitted to the hospital, or it may even be about half of the patients who are admitted to the hospital have diabetes. And diabetes has a significant impact on the outcomes of the primary illness, and managing the diabetes effectively does play an important role in the overall outcomes of the patient. So I think I invite Dr. Unnikrishnan to give us a idea about how this should be done and what is the best way of doing it, because there are so many different organizations suggesting different ways of doing this, achieving this, and he would be I think the best person to give us a good idea about this. Thank you.
Thank you, Dr. Rakesh. I'm also grateful to Dr. Jyotidev and team for inviting me. It's good to see some familiar faces here. And just to keep those familiar faces informed, this is the hospital I work. It is called Trivandrum Diabetes Hospital. We are a not-for-profit hospital, and we have a 60-bedded hospital with everything for diabetes under one roof. So many people asked me yesterday, when you left Cochin, where have you gone to, where are you working? So just for your information, so we have a cath lab to assess, to treat cardiology problems. We have a dialysis unit, look at nephrology. We have a podiatry service. So we have 4 operation theaters, one for bariatric, eye, foot. So we also have significant efforts to improve diabetes education and awareness. So I'm going to talk about now inpatient glucose control, and I'm going to talk about just 3 questions. How important is glucose control in hospital? What are the targets we must aim for? And what is the best way to achieve those targets? So if we look at surgery in a diabetic or a diabetic admitted in an ICU, it is a cat and mouse game, in the sense that insulin is a cat, and I'm not calling the mouse as glucose. So I'm calling them the metabolic mice, which means that we are not just talking about glucose, we are talking about a lot of other chemicals that come into play, the interleukins, IL-1, IL-6, TNF-alpha, and of course the growth hormone, the cortisol. And as you know, when the cat is away, the mice will play. So all these hormones, the growth hormone, cortisol, glucagon, adrenaline, the cytokines, fatty acids, all start playing up in an interplay, an orchestra of catabolism to result in high glucose levels. And that high glucose is because of 2 reasons. It's because all these metabolic mice would impair insulin action as well as impair insulin production, and therefore when insulin is not produced or when insulin is not working, you get hyperglycemia, and that's how an in-hospital or critically ill patient has high blood sugars. Beyond just glucose control, insulin has pleiotropic effects. It is anti-inflammatory, antioxidative, antithrombotic, vasodilator, cardioprotective, and it has been proven that in a surgical ICU, people with a blood sugar that is kept at 80 to 110 do better with a higher survival than people whose blood sugar is kept at between 80 to 200. So that's where we are. 80 to 200 compared to 80 to 110. So 80 to 110 actually did better. And it's not just about survival, it's also about reducing in-hospital mortality, it's about reducing bloodstream infections, it's about reducing acute renal failure, it's about also reducing the need for dialysis, prevalence of critical illness neuropathy. So many things are just adjusted by good blood sugar control. So I've talked about how important is blood sugar control in hospital. Let's look at what are the targets that we must aim for. So this is a nice sugar study. Unlike a surgical ICU, in this nice sugar study, there was really no benefit of keeping the blood sugar 80 to 110 in a medical ICU. So the authors said that no point in keeping sugars 80 to 110. So where should we keep it? So now the guidelines say that in hospital, you need to keep the blood sugars between 140 to 180. So that's the guideline for glucose control in an ICU. So the target, the threshold at which you will give insulin to control the blood sugar is 180, and the hypoglycemia definition is about 70. So that's the target. 140 to 180 is the glucose control you will aim for in the ICU. Let's look at the wards. Supposing a patient is admitted in a hospital ward, what are the targets you will aim for? So here again the guidelines show slight difference. 140 to 180 in the ICU has now become 100 to 180 in the wards, and that's because in the ICU you don't even want one episode of hypoglycemia, because that can be, these are critically ill patients and it can be potentially fatal in sick patients, so you don't want that. So here you have 100 to 180, and if you want to look at a pre-meal level, the threshold would be 140 and the post-meal glucose of 180 would be how you like to treat it. Hypoglycemia definition does not change. Anything below 70 is hypoglycemia, anything below 40 is severe hypoglycemia. So we've looked at how important is glucose control. We have looked at what are the targets we must aim for. Let's look at what is the best way to actually achieve these targets. So let's look at a case now. This is a 53-year-old gentleman with type 2 diabetes admitted for cellulitis, infection of the foot. He is on metformin and glimepiride and the fasting sugar is 280. He has leukocytosis. The HbA1c is 7%, suggesting that glucose control has been pretty good, but recently it has gone up. So how would we like to manage the blood sugar in this gentleman? There are some steps to manage glucose when patient is admitted in the ward, and the first step is to actually determine what regimen you want to give to your patient. One option could be a once daily insulin regimen. There's just one poke per day. Second could be a premix regimen, which is twice a day. Then you could give 3 short actings and 2 NPH, or you could give 3 short actings and 1 long acting, maybe glargine or degludec. Degludec has to be adjusted every 3 days, but glargine you can adjust every day. So these are the 4 regimens. But if you ask me which is the best one to choose, the best one to choose is a basal bolus with a 1 long acting and 1 short acting with each meal. So these are the choices, and the ideal choice would be basal bolus, because in a stable patient you can get quick sugar control and it is physiological. So next step, so once you choose that your patient should be on a basal bolus insulin, your second step is to decide on the basal bolus insulin dose. So that depends on the patient. For example, an emaciated patient would require about 0.3 units per kg body weight. A very obese patient on steroids, these people have significant insulin resistance, you'd like to give 0.7 units insulin per kilogram body weight. And normally built people likely to eat all their food in the hospital, if they're eating food, you can give them 0.5 units per kilogram body weight. So this patient maybe falls in the 0.5 category. So in a hospital, you will have a lot of patients with a lot of conditions. So you'll have to choose which regimen, which dose for each patient. For example, here is a situation. Supposing your patient is eating all the food, you can give a basal insulin 40 to 50% and a small bolus nutritional insulin with each meal. Supposing your patient is nil per orally or is taking only clear fluids, then you can give a basal insulin and you may not need to give a nutritional insulin. If your patient is nil per orally, you can just give a basal insulin and watch. Supposing I'm not talking about ICU patients here, I'm talking about stable patients in the ward. Supposing your patient is on a continuous Ryle's tube feed, you can give basal insulin and then nutritional insulin every 6 hours. Supposing your patient is on very high dose systemic steroids, there you'll have to give huge amounts of prandial insulin, not basal insulin, prandial insulin. So you will have to give about 70% prandial insulin and only 30% basal. So you will have to look at a lot of factors when you choose which insulin you have to give to your patient. How do you divide in an ordinary patient? How do you divide between basal and bolus? You give about 40 to 50% as basal and the rest 20%, 20%, 20% as bolus. So 20 plus 20 plus 20 is 60 plus 40% basal. So let's go back to this 53-year-old gentleman with type 2 diabetes who's got a fasting sugar of 280, is eating well. Let's assume that he's got a normal body weight. So he will require about 0.5 units per kilogram body weight. Let's assume his weight is about 80. So if his weight is about 80, 0.5 into 80 is about 40 units. And of the 40 units, you'll have to give you can give either glargine or degludec or NPH 24 units, and the rest you can give regular insulin, glulysin, lispro, aspart, 6, maybe 6. So 6 plus 6 plus 6 is 18 plus 24 is about 42. So roughly you can give your insulin like that as a starting. Then you will have to adjust the dose depending on the patient's condition. How to adjust these doses? Now, if the blood sugar is higher than the target range, evaluate the pattern of glucose elevation. If the fasting is elevated, you increase the total daily dose by 10 to 20%, and if the fasting is in target but postprandial is high, then you increase the nutritional by 10 to 20%. The reason is because if the fasting itself is high, fasting and PP is high, so you'll have to give the entire patient's dose has to be increased. But if only the postprandial is high, you can keep the basal same and just adjust the nutritional component. So what is the nutritional component? So this is the insulin requirement in a normal gentleman. You have a basal long-acting insulin like say glargine, and then you have a nutritional insulin. The nutritional insulin corrects for the food the patient is eating in the ward. And then you have a correction factor. A correction factor is a factor which you apply to bring the blood sugars back to normal. For example, supposing you have a patient who is going to eat lunch. Let's assume he's going to eat 3 chapatis with lunch and some rice and some curry. So then he is on basal insulin. You have to give about 8 units to cover that meal. But when you check the sugar before lunch, it's about 200. So it's not enough to only cover the meal. You have to bring that 200 to 130 and then give extra insulin to cover that meal. So that correction which you apply to bring that 200 to 100 or 130 is called a correction factor. There are many formulas for that, but it's, you can roughly take about 30 or 40 milligrams for 1 unit of insulin, and you can give 3 to 4 units extra. So the correction dose can be roughly looked at like this. The correction dose, supposing your patient's sugar is 300, you want to bring it to 150. So what is the blood sugar? It is 300. You want to bring it to say 100. So 300 minus 100 is 200, and that you apply the correction factor. Now what is the correction factor? The correction factor for human insulin is 1800 by the total daily dose, which means if a patient is on 60 units per day, 1800 by 60 works out to about 30. So let's assume the correction factor is 30. So you want to bring the sugar from 300 to 100. So 300 minus 100 is 200. 200 by 30 is about 6. So you'll have to add 6 units to that patient. These formulas are all available in the internet, and you can easily use them, and most of the time you will be doing by trial and error, giving a few units. But this is a good way to look at it. So to bring the blood sugar from 300 to 100, apply the correction factor and get the correction dose. The correction factor for human insulin is 1800 by total daily dose. For an analog, it's 1500 by total daily dose. So if you're using say lispro or glulysin or aspart, you'll have to take 1500 by total daily dose. So this is how you calculate. So let's assume a patient comes and in the ward, the fasting is 160. You increase the night dose and give some supplemental insulin. Supplemental is nutritional plus correction. Supposing at 12 noon it is 270, you have to adjust the morning dose on the next day, not that day, and for the temporarily you can give a supplemental correction factor. Maybe it's 270, you want to bring it to 100, so you have to reduce it by 170. 170 by 30 works out to about 5 units. You may have to give 5 units extra. And similarly, at 7 p.m. if patient is having hypoglycemia, you have to adjust the basal dose, and so on and so forth. So this is a correction chart. You can use any chart actually, but this is a correction chart. This is not a sliding scale. A sliding scale I'm going to come to later. This is a correction chart. But your correction chart has to be depending on your hospital. So if the blood sugar is less than 70, you will have to call a specialist and reduce insulin dose by 50%. Blood sugar is more than 150, you will have to add 5 units. So you can give the correction. If you don't have time or effort to calculate the correction factor, you can always give a correction chart. So I just want to criticize this sliding scale, which is now used by a lot of doctors to control sugars. Not physicians, but surgeons and anesthetists and so many other people. Sliding scale is, even yesterday we had a patient, I got a WhatsApp message that a patient has been admitted in our hospital. He was treated in a big hospital, and there they have given A sliding scale. A sliding scale is just something stuck onto into a notice board in the ward. If blood sugar is 100 to 180, don't give insulin. If it is more than 180, give 4 units insulin. More than 160, give 5 units. That is not, a correction chart is not a sliding scale. Sliding scale is something which the nurses can follow because the doctor has no time to see the patient. And doctor also at home does not keep on getting calls from the patient. He just from the nurse. So he just puts it stuck. Dear nurse, if blood sugar is 180 to 100, just give this. So the sliding scale does not take into consideration whether the patient is eating food or not eating food, or is about to eat food or has not eaten food. So just to give you an example of this, let's assume that patient has reached your hospital at 10 p.m. and has got admitted. And let's assume that when he got admitted at 10 p.m. his blood sugar is 380. So very high blood sugar. But we must remember that he has just had his food. So it's a postprandial sugar. But a sliding scale does not take into consideration any of that. According to sliding scale, if it is 380, you have to give 24 units insulin. That the nurse has been told because there is a chart stuck in the wards. So the nurse gives 24 units insulin. So 24 units is a high dose for this man. And early morning when the nurse checks the blood sugar, it is 70. It become very low. But the 70 means he is just going to eat breakfast, right? But the sliding scale doesn't know he is going to eat breakfast. According to sliding scale, 70. Just give zero insulin. Just don't give any insulin at all. So patient is not given insulin. But the patient, and also the patient is told, your patient knows sugar is only 70, let me eat little bit more. So they may have 3 idlis and some chutney and some sambar and some maybe even some tea with sugar and all that. So by 12 o'clock, the sugar has gone up to 311. Patient is going to eat actually, but patient is told to eat less because sugar is high. So 24 units are given, and by 4 p.m. again sugar is low. And because the sugar is low, a patient has been given a mango drink. This happens in most hospitals. And at 7 p.m. the sugar is now 100. But remember, 7 p.m. if the sugar is 100, according to the sliding scale, nurse is told don't give any insulin. So no insulin is given. But remember, patient has also got all these 3 low sugars in the morning. Patient is worried. So the patient has got a huge, good meal. They ate rice, some chapati, some maybe a little bit of fruit, some sweet, everything together they ate. And the sugars went up from 100 to 540. So when it became 540 at 10 p.m., patient is not going to eat anything at night, but 540 means, okay, urine sugar is brick red and the sugar is 540, 36 units of insulins are pumped in as per sliding scale chart. Patient wakes up at 3 a.m. with hypoglycemia and seizures. So this is a problem with sliding scale. From 380 to 70 to 311 to 49. So it's like a roller coaster insulin. Goes up, goes down. Why? Because you are trying to treat the past. You can't treat the past. You have to treat the future. So what happens in a basal bolus is you adjust the next day's dose and apply small corrections for today and then add that to the next day's basal or bolus. It's not to actually give according blindly without knowing whether the patient is eating or not eating or whatever it is. So at our hospital, at Chalaram Diabetes Hospital, we have our in-hospital protocol which we have trained our nurses, and so you will have to develop a protocol for your own institution. So we use this for our inpatients, for our pre-operative, post-operative, cardiac cath, angiogram patients, dialysis patients. Everybody is on this. So you have to develop. It may not be very grand. You may have a very small hospital with 5 or 6 beds. But for that hospital, depending on the number of glucometers you have, depending on number of nurses you have, you can develop your own nice small protocol and follow it. So it has to be institution-based. And of course the basal bolus is the best. I will not touch upon this because we have already talked about it. This is a rabbit-2 study which showed you that giving a basal bolus regimen with glargine and lispro can control the blood sugar in hospital in surgical patients. So basal bolus is the best. I think I have 12 minutes more. So when I look at this case 1, a 53-year-old gentleman admitted for cellulitis, best treatment is basal bolus insulin, and that's the ideal. Now let's look at another case, 68-year-old lady. She is admitted to hospital with a urinary tract infection. I'm not going into what medicine she's taking, so I'm not into that. So I'm just looking at, she's asymptomatic, she's eating well, and she is on a premix insulin. 12 and 10. So when she is on a premix insulin 12 and 10, she is getting control, getting better. Suddenly she became dyspneic. She started becoming breathless. She had acute respiratory distress syndrome, and X-ray shows all sorts of patches. So she has got an ARDS. She became sick, had breathing difficulty. She had to be shifted to the ICU. Very, very common situation. So patient admitted stable, old patient, now shifted to ICU, sick, not going to eat, probably intubated and ventilated. She's on a ventilator. Sugar is 442. How do you control the sugars? So best way to control that is using an insulin infusion. So what's an insulin infusion? It's very simple. Think of two taps, one tap with glucose flowing and one tap with water flowing. Adjust both these taps to keep the blood sugar normal. That's an insulin infusion. You'll have to do that. That's the best way to do that. So briefly, put 50 units of short-acting insulin in, so that there is 50 units in 50 ml of normal saline. So you may have to give 50 units of short-acting insulin and 49.6 units of normal saline, so that it is exactly 50 and things like that. That your nurse will tell you. So then basically 1 unit of insulin is there in 1 ml. So that's how you start. And then you divide the blood sugar by 50 to decide the bolus. So if this patient's blood sugar is 300, let's divide 300 by 50. So 300 by 50 is 6. Immediately you give 6 units IV bolus. So that's the first thing you push in 6 units straight. Then you give the patient an infusion. How much should be the infusion? Divide the blood sugar by 100. So if the blood sugar is 350, now 350 by 100 is about 3.5. So 3.5 units per hour is a good starting dose for giving insulin infusion. What's your target? Your target in an ICU, as I mentioned, is blood sugar 140 to 180, and check the sugar hourly. If it is within the target, don't do anything. If it's above the target, increase the rate. Below the target, decrease the rate. How much to increase, how much to decrease? This is, of course, our algorithm, I think, which shows that how the nurses adjusted in the Chalaram Diabetes Institute. So according to the sugar, for example, if the sugar is 350, you may increase it by 5 units per hour. If it is just 200, you may increase it by 2.5 units. But you have to set it for your own hospital, and your nurses have to be trained according to that. So normal saline you can give if patient is dehydrated. When the sugar is low, you can even change to dextrose. If patient is nil per orally, if you just keep on giving insulin, patient can be catabolic. So you may have to give some glucose dextrose saline also. When do you stop this insulin infusion? If the patient's blood sugar is below 80, you stop the insulin infusion, give some dextrose, check blood sugar every hour till the blood sugar has come up. So if the patient is on insulin infusion and decides to eat, if you are going to give a patient regular insulin, supposing the patient is going to eat at 1 o'clock and you want to give some regular insulin, you want to give some human insulin R or Actrapid or Insuman R or Insugen R, some regular insulin, it takes half an hour to act. So if your patient is going to eat food at 1 o'clock, you will have to give the regular insulin at 12:30. Okay, and stop the infusion at 1 o'clock and let the patient eat at 1 o'clock. But if it's an analog insulin like Aspart or Glulysin or Lyspro, no need to wait. On the insulin infusion itself, you can just give a bolus and then give you a shot of basal insulin. So that's possible. So this is a way to do that. So coming back to the 68-year-old lady who had a UTI, developed acute respiratory distress syndrome, shifted to the ICU, now is on a ventilator, and now the blood sugar is 442. I think this patient, the best thing is to put the patient on insulin infusion. The insulin infusion pump is not the insulin pump. The insulin pump is an ordinary subcutaneous pump. Insulin infusion is an intravenous infusion pump, in which insulin has to be given IV into the drip. So I have looked at how important is glucose control. It's quite important. It can reduce mortality and morbidity. What are the targets to aim for? 140 to 180 in the ICU, less than 130 in the ward fasting, and less than 180 post meal in the ward. So that is a target, and which is the best way. Give intensive insulin injections, which means a basal bolus regimen for patients who are stable and who are eating, and insulin infusion IV to patients who are sick and in the ICU. So this is our own hospital's protocol, but you need to have your own uniform protocol, which can be used by multiple specialists, which I mean not just doctors but nurses, paramedics, diabetes educator, resident doctors, the senior specialists. Everybody should be trained and they could use it, and then they can apply this and individualize it for your own care, and that's how your patient will do better. Ladies and gentlemen, thank you for listening to me.
Thank you, Dr. Uni. Would you join me here? So I think he has given us a very good idea about why diabetes control is important and how do we do it. He has given us two very illustrative case studies which have shown us the importance of using a basal bolus protocol in most situations and how to avoid a sliding scale because of the problems that can be there. I would open the house for questions, and before you could come up with a question, I just wanted to ask him one question. How important is stress hyperglycemia? So could you just tell us something about that?
Stress hyperglycemia is a situation applied to a non-diabetic person who is now coming to hospital, and then you check the blood sugars, and blood sugar is in the hyperglycemic range. How do you know it is stress hyperglycemia? You do an HbA1c, that's a simple test. If HbA1c is high, that is pre-existing diabetes. If HbA1c is normal but blood sugar is 200, then it is stress-induced hyperglycemia. When do you treat it? If the blood sugar is more than 180 post-meal or 130 before breakfast, then you treat it. After that, what do you do? When the stress is over, the blood sugars come to normal, so don't give any treatment after that. If it is stress hyperglycemia, and then do a GTT 2 months after the acute event to reclassify the patient. Supposing it is pre-existing diabetes, the HbA1c is high, you are going to need some sort of medicine to give the patient and discharge. But if it is not, HbA1c is normal and it is pure stress hyperglycemia, repeat GTT after 2 months. Remember, just like gestational diabetes, these patients are also at risk of future diabetes because a small stress of hospitalization has pushed them into diabetes. So lifelong diet, exercise monitoring is good. So in CKD patients, managing hyperglycemia is a big challenge because earlier I was working in an endocrinology diabetes department, but now I'm looking after a whole hospital, so I look after the dialysis patients. So it's very tricky. What happens is that the kidney, when it fails, the kidney produces basal glucose. Kidney has gluconeogenesis. So when the kidney doesn't produce glucose, the basal or fasting glucose level comes down. Second thing is, kidney normally produces an insulinase which can degrade insulin, but when the kidney fails, insulinase is not produced, so you have more insulin effect. Third thing is, hyperkalemia can actually stimulate insulin production. So these are all factors which improve blood sugar level. Finally, as you know, kidney failure patients don't eat, so sugars come under control. So these patients, most of them require repeated injections of short-acting insulin, like Lispro or Aspart or Glulisine. Short-acting insulin is good in many patients. If the fasting is high, you can add a basal insulin. But short-acting insulin is a good way to do because once they have already got end-stage kidney disease, they have got heart disease, they have got eye disease, you don't want hypoglycemia. So minimum small dose of short-acting is good. If fasting is high, add a basal. I'm not a very purist, so in some patients I use our premix insulin also to control. So all three can be used, but the dictum is minimum dose to just keep the blood sugars near the upper limit of normal range, not near the low limit.
In many situations, we have to use IV or oral steroids in diabetic patients. In that situation, how will you titrate the insulin requirement according to the dose of the steroid?
Okay. So I did show a chart on that. So I did show a chart on how to, one is that the starting dose on steroid patients is higher. It's about 0.7 units per kilogram body weight. And second, patients on steroids require a huge dose of prandial insulin because the food that you eat, the glucose that goes up because of the counter-regulatory effect that insulin doesn't work because of the steroids. So your bolus requirement will be about 70% and bolus basal will be 30%. Usually we give half as basal, half as bolus. But in a steroid patient taking high dose steroids, you may have to give more of the bolus because you want to keep the blood sugar from shooting up to high level. These are some of the principles. But my slides are there and we can share it with you. I showed a chart of different groups. Steroid was there in there. Sorry? No. So I can share the chart with you, that's nice.
Excuse me, sir. In rural areas, there is no facility for to see HbA1c. Then how can we can diagnose stress hyperglycemia?
So as I said, see, it's a clinical diagnosis most of the time. Supposing patient tells you that my blood sugar was normal 1 month back, now after hospitalization it has gone up, you know it is stress hyperglycemia. Supposing patient has absolutely no signs of any diabetic complications, it could be stress hyperglycemia. Many times you just don't know. If you don't have HbA1c, you just don't know. So you can treat the patient, see the sugars at discharge. If the insulin requirement is very low, say if it is below 12 units a day or something, you can just stop it at discharge and you can give diet and exercise and reclassify after 2 months. There's no problem. You can easily do that. But now let me say HbA1c is available routinely. There is even a point of care HbA1c device which you can just keep in your clinic and you can test it. It's not very accurate, but it will work out cost effective and you can use it in small clinics and hospitals.
Even if you are not able to classify, the important point that Unni has highlighted is that you need to treat the hyperglycemia, irrespective of whether he had diabetes or not. You need to treat the hyperglycemia at that point of time, and then subsequently it is important to decide whether he needs continued treatment or not. So if he's on a low dose, you can stop insulin. If he's on a higher dose, then you may adjust it accordingly. Use your clinical sense, and also try to use these point of care devices, as he said. If there are no further questions, then I think we can close the session, and I thank Dr. Unni for the excellent presentation.